Thank you, Constance. Good morning. You can tell by the standing room only crowd here that the subject of artificial intelligence has captured everybody's imagination, all the way from reality to science fiction. And at the same time, healthcare has been struggling with problems for years, and digital technology has showed up, and we've had some benefits, but we still haven't solved some fundamental problems. And I want to just talk a little bit about bringing those two together, because it's really that context that drives the distinct promise of artificial intelligence. Because, in fact, if you just step back and look at the traditional challenges of access, affordability, effectiveness, many people characterize that as the iron triangle. You can't fix it without breaking something. You try to make access better, you make cost worse. And the application of simple technology hasn't really broken the iron triangle. What's interesting is that the presence of artificial intelligence as a type of technology actually gives us the first real opportunity to solve those problems without breaking one thing to fix another. And that's a distinct difference than just traditional technology and digital technology. And you started to hear that today. I actually think Dr. Vega made a really important point. You'll hear that in my comments, which is some of the real opportunities here are to solve some of these hard problems. And in fact, there are two specific problems that are important to think about. The first one, hang on, let's see if we can get this to go. I can't get this to advance, but maybe you can back there. The first problem is fundamentally focused in the affordability challenge. And here's the best way to think about it. It turns out that if you actually look at rich countries in the world, no matter how they're organized, whether they're public or private, whether they spend a lot of money or a little money on healthcare, they actually all see the exact same problem, which is their costs grow 1% to 3% faster than their GDP. That's the same in the US as it is for the OECD on average. That's the same as the lowest quartile companies in the OECD. And that's best explained by work that started back almost 30 years ago. William Baumol, an economist, characterized this as the cost disease. He basically said labor-based economies, healthcare being one, 65% of the input costs, can never grow at a rate slower than the economy that it's in, because the wages have to grow at the rate of the economy that it's in. And in healthcare, when you add scientific innovation that converts non-disease to disease and an aging population, you're 1% to 3% faster than GDP. No amount of waste elimination is going to solve that problem. If you can't figure out how to get the work that's being done by humans to be done by machines, it's an unsolvable problem. Now, automation was an interesting opportunity for us, but it didn't yield the results we hoped for, because in order to substitute for the work that people do, it's not just simply routine tasks. You have to begin to substitute for non-routine tasks. In fact, if you just looked at job creation in the United States since the 1980s, almost all the job creation occurred in non-routine tasks, both cognitive and physical tasks. So our ability to begin to work on non-routine tasks is critical. The second observation is the following, which is that people who are seeking healthcare are actually forming their expectations of how healthcare should be from their perceptions and experiences going on outside of healthcare. And so the gap between people's expectation of how healthcare is and how it should be is simply growing larger. And that gap has to be filled, because if it doesn't get filled, it creates an unstable situation for the healthcare sector, and one that's either going to be filled by non-healthcare entrants or by legislation and regulation imposing an expectation that healthcare is really delivered to citizens on their own terms, where they want it, when they want it. You can't take a physical model of care the way we do it today and organize it to meet individuals on their own terms, where and when they want it, by simply trying to take an analog system that we have today and just making it more efficient. In order to be able to serve individuals as markets of one, you have to put technology in that allows us to take a healthcare system that's physical and make it available for individuals on their own terms. Again, simple technology doesn't solve that problem, but technology that learns can solve that problem. The challenge is that there's no standard definition of artificial intelligence. And because of that, it creates a great opportunity as well as misperception. Artificial intelligence is actually a constellation of technologies. At the core of it is the ability for technology to learn without explicit programming. That's really a critical difference between artificial intelligence and other technologies. Every other technology solution that's existed to date, a human has basically had to make a change. It observed, and then it came back and put a change in. But artificial intelligence actually learns on its own. For example, artificial intelligence took the ability for voice and speech recognition, which essentially languished, and made it available for us in Google Home and in Amazon Alexa, because nobody knew the difference between my voice and my son's voice, and they couldn't sell me a device out of the box that did. But within a week, without anyone programming it, knows the difference between my voice and my son's voice. It has the ability to learn. It has the ability to learn because it's listening to the data. It's then also surrounded by a constellation of other technologies. Technologies, for example, that allow us to look at words written by a doctor and present it to us in essentially a picture of handwriting, and translate that into a digital byte that can then be used for another purpose. That ability, for example, to look at the written word, and Don Rucker talked about this, and convert essentially unstructured data, a picture of a piece of handwriting, into information and bytes that can actually be used for processing, actually is one of the single most promising initial use cases of artificial intelligence, not just in healthcare, but across all of society. Because a tremendous amount of human labor is being consumed right now, just reading documents and then translating them into digital bytes that somebody can act on. So the way I think about artificial intelligence is really a set of 4 large-scale competencies: sense, comprehend, act, and learn. And much of the initial narrative around healthcare has been focused primarily on artificial intelligence in the comprehend and learning capabilities. So the ability to look through large amounts of data and to make better predictions or to discern certain kinds of judgments about what might be the best outcome. We've talked a lot about that in our sector, but in other sectors, and I think in healthcare going forward, it's things like sense and act that are actually going to provide some of the greatest promises. All of those are part of artificial intelligence. If you actually look broadly across the use of artificial intelligence in healthcare today, and I'm thinking about payers and providers and governments and life sciences, you see it in real life today, but it's not necessarily all in the front of the house in terms of patient-facing, but in the back of the house, for example, in the drug industry, a lot of artificial intelligence is being used right now in research and development in terms of understanding and predicting the promise of certain molecules. In fact, the basic discipline of prediction and data science has transformed in the last half-decade because the limitations of traditional statistical methods have been swamped by what can be done with technology using machine learning. If you look at a competent data science organization right now, it has to have artificial intelligence capabilities and data scientists that understand how to use them, or it simply is not competent. And that has nothing to do with robots taking care of patients. That is the fundamental migration of data science has already moved to a point where it's already dependent on that. And then you're beginning to see it appear in common business applications that are beginning to find their way into healthcare. I described to you the use of technology to understand your voice. Outside of healthcare, many customer service applications, you're beginning to interact with technologies and agents. Some of that you directly interact with the technology, but in many cases, you're interacting with a human agent who is actually being supported by a technology to make a better decision. And you're starting to see this in healthcare, not just in simple customer service situations, but for example, there are interesting companies right now that are looking at the challenge of making an appointment with a doctor. And as you all know, the way it works today is you call and they basically tell you, here's the next available, take it or leave it. Here's the next available, take it or leave it. It's essentially a forced auction model. The idea that people are working on right now is, I know something about you. I know what days you usually come because I look at the history. Maybe I know something about people like you. I can actually tell you which appointments are most likely to fit your preference rather than what the next available is in order to try to get a better match. Now, you don't act directly with the technology. You're still talking to a human, but the human is now informed differently about what options it should give you because it's able to understand more about you. And in early work, organizations that have used this have been able to demonstrate that their physicians actually are busier because all those appointments that were made with people who accepted a take it or leave it proposition and didn't show up are actually making appointments for times they're going to show up for. So it's paying for itself because people are actually coming in when they agree to come in. What's important is that most of the artificial intelligence we're talking about sits in the middle category, which is called weak artificial intelligence, single-purpose artificial intelligence. Nobody is really talking about replacing the human brain in totality. Dr. Vega made the point, and I agree completely. No serious person has any belief that technology is going to replace a doctor. In fact, even Brian Osborne, who published the work in 2013 about 47% of U.S. jobs being replaced by 2050 by artificial intelligence, if you look at the paper and you look at the jobs that they had said had a less than 1% probability of replacement by artificial intelligence, you'll see healthcare jobs in there, because the judgment required is very significant. That is not to say, though, that tasks that doctors do can't be performed by technology. Whoops. We've actually looked across where we think the opportunity for artificial intelligence is going to play itself out economically by category of, a series of categories here. And we published this. By 2026, we think that the greatest amount of economic opportunity is going to be in a series of things. If you look at the top of the list, robotic-assisted surgery, virtual assistant, and administrative workflow. Now, I want to just make a point about robotic-assisted surgery. That economic capacity is primarily coming through reduced length of stay and resource consumption. It's coming through economic capacity, not through clinical outcomes. Because what's happening is the surgery is getting so good that we're both moving the site of surgery as well as we're changing the outcomes in terms of the complication rates and therefore the length of stay, creating physical capacity to do more work without making the factories bigger. And then after that, when you look at things like virtual nursing, you see this in two different places. One of them is a physical robot. There are shortages of nurses in Japan right now, in a country that has essentially no birth rate and no immigration. And the work being done by nurses that you see today, if you went to a hospital in the US, are being done by anthropomorphic agents that are moving around and collecting basic information. Now, there's still nurses making judgments, but the data collection and the observation is being done by a physical robot. Similarly, you're beginning to see companies build technologies that can provide the kind of coaching and disease management that's today often done by a live conversation with a nurse or a coach, essentially with a technology or an avatar, getting both, in some cases, both the benefit of less expensive resources to solve the same problem, and in some cases, better efficacy, because we know for an absolute fact that there is actually a stigma associated with sharing your information with another person, and in many cases people are much more willing to be honest with a technology who's asking them about whether or not they're managing their life more than it would be if they were interacting with a human being who made the same call and asked the same question. This happens in mental health conditions, this happens in heart failure, this happens in diabetes, so there's a lot of interesting things there. And then administrative workflow. We're seeing this play itself out in the reading of documents for many purposes, insurance administration and payment. In fact, the two largest sources of labor in the healthcare provision system, outside of the clinical labor, are labor associated with payment and labor associated with essentially customer service, making an appointment, finding out information. Both of which are amenable to technologies available today to begin to take over some of those tasks. So we think about it categorically as cost reduction, outcome improvement, and consumer experience. And while a lot of the newspaper ink about artificial intelligence in healthcare has been focused on outcome improvement, a lot of the economic opportunities and real uses and real benefits actually sit in cost reduction and in the consumer experience side of the equation, both addressing the labor productivity issue that I described in the beginning, as well as the gap in expectations between how healthcare is and how citizens expect it to be on a global basis. We did some analysis recently just simply looking at the labor force for clinical labor, which, if you just step back and assume present course and speed, the World Health Organization predicts by 2030 a 15 million person clinical worker shortage. It's a big number. And that's not just a poor country problem, that's a rich country problem. There's some work that we've been doing in Finland recently, and an economist there told us that's the second fastest aging population, by the way, in the world after Japan, because no immigration, low birth rates. Their population distribution is a barrel, it's not a pyramid. And there are people there who predict that by 2050, every single person in the workforce would have to work in healthcare. Every single person. to solve the problem with the supply and demand. Obviously, an unreasonable position to take and has nothing to do with cost savings. It is physically impossible to solve that problem. We looked at this and we just looked at clinical tasks. And our own modeling says that technology that's available today gives us the opportunity to move work both to citizens, the patients themselves, and to smart technology in some combination, creating almost 30% capacity from the existing labor force. So instead of having a shortage, we at least begin to close that shortage significantly. And then you can begin to imagine what's happening even in emerging countries, where you can take a person who has been displaced from their job because of automation, and you're starting to see experiments like this now, and with a little bit of training and a piece of smart technology, convert them into a frontline healthcare worker. They don't actually need to be a clinician, but a citizen with a little bit of training and a smartphone can actually go and physically point that phone at a patient, get an interpretation that can then be shared with a clinician, and they can actually extend their workforce in ways that nobody's thought before. Now, in terms of getting it real and getting it into work, here's the interesting challenge. We talk about it as technology, but it's not just technology. In fact, we have demonstrated repeatedly that if you think about putting artificial intelligence into an organization as simply a technology problem, it fails on many counts. The first challenge here is that you actually have to redesign the work processes before you put the technology in. People who have put in automation and automation with artificial intelligence into an existing work process have consistently never been able to reap the productivity rewards that they expected. Never. If they don't redesign the process, there's no point in introducing this kind of technology into it. That's a big job. Second issue, data. Artificial intelligence is a learning technology. It is not just simply about conducting the transactions. You have to build an organizational culture that is mindful of harvesting all of the data from the transactions and recirculating it back into the process. Otherwise, you don't get the value. This is not, I make this statement, it shows up on a slide, it's not that simple. Most organizations haven't organized themselves at all to think about harvesting the data that's flowing through the transactions and putting them together and reusing them. And the third is the workforce. This is a significant issue. We are entering into a world where humans and technologies work side by side. In manufacturing, this has already been described as cobots, co-worker, robot. Human-machine dyads require a set of skills that have been described as middle skills that simply we don't understand today. They don't exist. You cannot put a technology and a human together and expect them to get the most out of it. An example of one of those skills is what's often described as intelligent interrogation. For me to get the value of this technology, I need to understand how to ask it the right questions to get the right answers back from it. We are going to have to develop an entire set of competencies for our human workforce in order for them to work side by side with technology and get the most out of it, because the technology amplifies the humans and the humans amplify the technology. In healthcare, as in all of society, this is not about going from humans to machines. It's about going from humans to humans plus machines. That's where the amplification effect exists. That's where the real opportunity in healthcare is going to exist. And I'll end here with a quote from Dr. William Mayo, one of the two Mayo brothers, 150 years ago. Will wrote this interesting quote. The aim of medicine is to prevent disease and prolong life. The ideal of medicine is to eliminate the need for physicians. Now, Will didn't know anything about IT or AI. Will was speaking as a doctor, but listen to what he was saying, and think about it 150 years later. What he was saying is that medicine exists to make people better. It's not about the doctor. It's about making people better. Today, we're having a conversation about artificial intelligence. We often get stuck on a negotiation about the role of the doctor, as opposed to stepping back and saying, you know, that's actually not the way to think about it. The way to think about it is people wake up and they're sick and they want their problem solved. What is the best way to solve that problem? Nobody has any expectation that we can make technology replace all of human judgment. But this is really not about negotiating the role of the doctor. This is about solving the problem of individuals who are sick. I see a tremendous opportunity here for artificial intelligence, and we're just at the beginning. In the child's life cycle, we're maybe entering into elementary school. We're not even close to middle school. And many times people look at artificial intelligence and they take a sort of a snapshot view and they say, that doesn't work. It's illusory, it's mythical. Well, it'd be the same as looking at your 7-year-old and saying, they can't perform adult functions today, they'll never be an adult. That's not how you think about it. What you understand is there's a maturation phase, and we have to ride that maturation phase. And therefore, even if the technologies are not available today for the class of problems that you're using, if you don't think about how it's going to affect that business and introduce itself into that business pretty quickly, you're completely missing the point. So I think these kind of meetings are fabulous because part of my goal here is to get people to think widely about artificial intelligence. It'll be interesting to see these meetings will get bigger before they get smaller, and hopefully I'll get to enjoy some more conversations with you about that. Thank you. Constance?